All right, so today, I know you guys got me 2 weeks ago for something different. What did we talk about 2 weeks ago? Gun control, gun safety, not gun control, gun safety. So this is the other piece of safety, and not quite a smoking gun, but it is something that takes more lives than smoking guns, in fact. So today I'd like to spend a little time talking about antibiotic stewardship, and this is has been a growing kind of effort and movement nationally over the past 10 years, driven by professional organizations, Academy of Pediatrics, mostly the Infectious Disease Society of America, and Pediatric Infectious Disease Society, because we're approaching a time when we won't have antibiotics to treat some of the infections that we have to deal with. And the good news for us here locally is that our antibiogram is still pretty good. We still have the utility of a lot of antibiotics that other people don't. But we have to protect those resources, and the strategy to do that is called antibiotic stewardship. And the take-home message is right there. It's everybody's responsibility to think about how we prescribe antibiotics, when we start them, when we don't start them, because that's sometimes the harder thing to do, and how we can make the best use of the antibiotics that we have available. So today I'd like you to finish this lecture being able to identify inappropriate use of antibiotics, talk about a rational approach to antibiotic prescribing. We really want to see increased use of narrower spectrum antibiotics and reduce the unintended consequences of broad spectrum antibiotics, which we're familiar with and we'll review. And then really the hard part is know when to discontinue antibiotics that are not necessary. And sometimes if that's the only thing that an infectious disease consult can do for you, we think it's worth it, because we make our 50 cents stopping antibiotics. These are our resources, these are our best tools, and so we want to preserve them. And knowing when to say no is one of those critical things. So here's a brief history of antibiotics. Everybody remembers, and some people remember, the sulfonamides of the 1930s. Dr. Bonner? Yeah. All right, very good. A few of us remember beta-lactams and amino glycosides in the 1940s. No, I'm not going to point anybody else. But we've had this steady growth of antibiotics in classes of antibiotics over time. We've gotten rid of some. Chloramphenicol we don't use anymore. It's not available in the United States. Tetracyclines, we've gotten better ones. Macrolides, we've gotten better ones over the past 20 years. A few new classes here. Here's your quinolones, your fluoroquinolones, lincosamides. Trimethoprim was really the last major new class. These are the dihydrofolate reductase inhibitor antibiotics, last major class for gram-negative rods. And in the early 2000s, drugs like particularly linezolid would be the one you know about here. So this new antibiotics have slowed down over time in terms of production, and part of it was that there was this general feeling that, wow, we've got all these great antibiotics. We don't need to continue doing research and develop new antibiotics because we've got great ones and they're never going to go away. But the fact is, these germs are smart. And germs, in fact, even when you go back to the pre-antibiotic era, germs already carried resistance genes in them, the bacteria did, that affect some of the antibiotics we use. There's a direct relationship, almost like this, linear, that the more antibiotics you use, the more resistance you develop in bacteria. There's a very, for those who believe in evolution, which I think most of us should, evolution happens, and bacteria and antibiotics are a perfect example of where we know evolution happens. The more antibiotics you use, the more you select for and drive resistance. So this is considered a public health crisis. At least 23,000 people die each year because of antibiotic-resistant microorganisms in the bacterial class, and at least 2 million illnesses nationwide each year due to antimicrobial resistance. That's a good number. That's a lot, right? This is half the number of deaths each year as the opioid epidemic currently. Now, the opioid epidemic has come on much more quickly, but antibiotic resistance has been slowly building. And here's a good example over time. Carbapenem-resistant Klebsiellas were extremely rare in the early 2000s and have increased since about 2006, 2007 in nursing home populations, ICU, and even outpatient populations now. But looking at 1 to 2% in outpatient populations, you're getting a little over 5% in the ICU setting. ICU setting is a high-use place for antibiotics, and it's a relatively closed community. And so that sort of sets up the situation for evolution to happen and to drive resistance and for those organisms to hang around. They hang around in the hospital. We know what bugs are in the different ICUs in our hospital that tend to be problematic. Okay? But these so-called KPCs, Klebsiella pneumoniae carbapenemases, have partly come because of medical tourism to other parts of the world where people will go for surgeries or other medical procedures, and other parts of the world use antibiotics even more freely than we do. And the overuse of antibiotics or inappropriate use is what has driven these resistant organisms out of the closet. The risk of death when you have a carbapenem-resistant Klebsiella is more than double that of the non-resistant strains. Does that mean it's really more virulent? Not exactly. These aren't virulence factors per se, but the difficulty is in treating them. It's in the delay in starting appropriate antibiotics, because if lab identifies Klebsiella, you say, oh, Klebsiella, no problem. We're going to give it a little of this, a little of that. And but then 2 days later you find out, oh, it's resistant to everything that the patient's on, and no wonder your patient's not doing better. Okay, so this is they're not necessarily more potent organisms, more virulent organisms, but there is an increased risk of death. Patients who are at highest risk are patients who receive a lot of antibiotics: chemotherapy patients, complex surgery patients, joint replacements, organ transplants, an immune-compromised group, other chronic conditions, and especially dialysis units. We know that dialysis patients have a lot of exposure to vancomycin and have really driven the prevalence of vancomycin-resistant enterococcus over the past 30 years. When I was a medical student, I think I've told this story in the micro course, vancomycin-resistant enterococcus was brand new, and everybody was scared to death because there wasn't anything to treat VRE. And one of the first patients I had to go in and examine was a patient who was dying of AIDS and colonized with VRE. And as a third-year medical student, I don't know who was more nervous, me or him. I came out of the room, I'm in mask and gown and gloves and stethoscope and everything, and doing this to listen to his chest and looking in his ears, and I'm walking out thinking, oh my God, do I have to throw my stethoscope away? Do I need to get a new ophthalmoscope? And all these things, because that was the panic of VRE. Good news is hand washing is the best thing. So groups at particular risk, these aren't the highest risk, but they are at increased risk of antibiotic-resistant infections, and you can see young children and premature infants, again, that affect the pediatric population, elderly because of recurrent infections, especially urinary tract infections in elderly nursing home patients, pneumonias as well. Soldiers and veterans actually have a fairly high exposure to antibiotics, and for many of them, their exotic travels, they're exposed to more germs, and their differential diagnosis is broader, so they tend to get broader spectrum antibiotics. But our young children, we have made some good strides for things like pneumococcus over the past 20 years, right? We've vaccinated away the vast majority of invasive pneumococcal disease, and in doing so, the pneumococcal strains that are actually circulating now are more friendly. They're more susceptible to antibiotics. 20 years ago, if you pulled a pneumococcus out of a patient's nose or ear, 50% chance it was resistant to penicillin. Now, 5 to 6% chance it's resistant to penicillin. So we vaccinated away those more resistant organisms, and at the same time, our antibiotic stewardship, promoting, especially in pediatrics, to reduce the use of antibiotics inappropriately has helped make those strains more friendly. A little more data, you've got to especially think about your chemotherapy patients. 60,000 patients with cancer will be hospitalized with fever and neutropenia, and 1 out of 14 of those will die. This is Dr. Girudi's big fear. This is the reason that Dr. Girudi is very aggressive, I think is fair to say, in use of antibiotics, because these patients with fever and neutropenia have a very high death rate. They're some of our most compromised patients. The difficulty is when you've done the workup and looked for all the different pathogens. You've got your blood cultures, you've moved your central line, you've ruled out infection. It's knowing when to stop the antibiotics because their fever and neutropenia may not have resolved. And so the Infectious Disease Society has developed specific guidelines for de-escalation of therapy in patients with fever and neutropenia. Community-acquired pneumonia is another area where there is a lot of use of antibiotics, 5 to 10 million cases each year, over 1 million patients hospitalized. A lot of these are viral, followed by bacterial. We know that in the adult population, they use a lot of fluoroquinolones, a lot of macrolides to treat pneumonias. And these are some of the drugs that are almost easy to use and easy to prescribe because they're once a day or twice a day, they're well tolerated, and they're short courses, 5-7 days, and it's fairly quick. But a lot of those infections that are viral clearly don't need antibiotics. And community-acquired pneumonias are the #1 cause of death from infection in the United States, and that's more than breast or prostate cancer. All right, so we have kind of a perfect storm. Over time, there are fewer and fewer companies actually doing research on developing of antibiotics since the mid-1980s. Around 1990, there were 18 companies studying antibiotics, and around 2010 or so, they're down to 4. Now, some of these companies have merged into mega companies, and so that explains the overall number decrease, but the amount of research that's happening on antibiotics has gone down overall as these major pathogens, MRSA, VRE, and your fluoroquinolone-resistant Pseudomonas have increased over time. And look at these resistance rates here, looking at 30% and even 50 to 60% for our MRSAs. And remember, MRSA is not inherently any more virulent than MSSA. They can have the same severity of infection. Sometimes MRSA carries toxins that MSSA doesn't, that PVL, Panton, Valentine, leukocidin. But in general, the resistant organisms are not any more virulent than the non-resistant or the susceptible organisms. Okay? But this is part of the storm. If there's less research, what this really means is that NIH and our public dollars have had to drive antibiotic research. We've had to incentivize antibiotic research through federal mechanisms, giving tax breaks to companies in the hundreds of millions of dollars kind of level to incentivize them to develop new antibiotics. So if you follow the money, this is newly launched antibiotics within the past 2 years. Avicaz is a combination antibiotic that is ceftazidime avibactam, I believe. And you can see that it's in its first 2 years, it's sort of in the $75 million range in terms of its total sales. But compared to other new antibiotics, here the scale is in $500 million increments, and you can see Avicaz just barely makes that compared to these other drugs that we're more familiar with. Symbicort, Vyvanse, you're up to almost $1 billion. Januvia for type 2 diabetes, you're over $1.5 billion. So it's like winning the lottery a couple of days ago if you own Januvia, right? So the antibiotics are not high cost in general compared to other things, and antibiotics are for very short-term use. They're not chronic medications that are taken daily by hundreds of thousands of people like this. We really don't want to have to use antibiotics. And so the economics of developing an antibiotic that's not going to be used chronically for hundreds of thousands of people like these other drugs doesn't favor developing the antibiotics by these companies. And the statistics that are available suggest that less than 5% of pharmaceutical venture capital goes to the development of antimicrobials. They're just not money makers or big good investment payoffs for the people who have excess capital to invest. So a leading factor in the increasing prevalence of antibiotic-resistant and its illnesses is the inappropriate use of antibiotics both in humans and in agriculture. We know that at least 30% of antibiotics prescribed in doctors' offices and emergency rooms are unnecessary. RSV, remember, does not stand for Rocephin-sensitive virus. It is respiratory syncytial virus. That's Bob Jackson's famous quote. Oh yeah, Rocephin-sensitive virus. 1 in 5 resistant infections are actually caused by germs from food and animals. The agriculture sector is in livestock are one of the biggest offenders and the biggest users of antibiotics that permeate into the resistance among those animals that is then transmitted to humans. And so curbing the use of antibiotics in agriculture has been very difficult. We know that if you treat chickens with antibiotics, they grow bigger, they have more breast meat, they're more tender, they live longer, they have fewer health problems just because they're on antibiotics. And so for someone who's growing chickens economically, it is very beneficial to them to have those chickens on antibiotics. But those chickens carry salmonella. Remember the CDC just reported a couple of days ago, don't dress up your chickens for Halloween because of the risk of transmitting salmonella. I'm like, wow. Okay, so Sarah can tell us about that over coffee. All right, so what is antibiotic stewardship all about? CDC has developed this curriculum with infectious disease specialists, and really there are 4 major core elements of the CDC plan for antibiotic stewardship, and this is specifically related to outpatient. One is that there has to be a commitment, a demonstrated commitment by providers. We have to understand and be willing to stand up for the non-use of antibiotics, for stopping antibiotics when they're not necessary, and we have to educate our patients about that. Okay, there's still a large expectation of receiving antibiotics. We have to work for action for policy and practice, so we can set up antimicrobial stewardship procedures, and I'll review some of those in just a minute, to limit antibiotic prescribing or to reserve some antibiotics in hospitals in particular for only severely ill patients. Tracking and reporting is important, and that's your antibiogram. That's a great place to start, but it's not the whole story. It's aggregated data over the whole hospital, including and our system, including inpatient and outpatient. And what we really need are some strategies like unit-specific antibiograms. We need age-specific antibiograms. We'd really like to know, of all those MRSAs and MSSAs, really what's the ratio in pediatrics compared to our adult population? That would help us be better prescribers. And we're working toward those things. And then education and expertise, and Medicare has mandated that all hospitals develop and implement an antimicrobial stewardship program. Hospitals are expected to pay both physicians and pharmacists to direct antimicrobial stewardship programs in order to reduce the inappropriate use of antibiotics and to ensure that there is, when necessary, someone who's going to stand up and say, no, that prescription is not appropriate, not necessary, keep moving on. So here's some of the blurbs that you may have seen in the media. Pediatricians and family practice doctors prescribe the highest percentage of antibiotics. Nearly 2/3 of rapid strep tests were sent unnecessarily, primarily due to the presence of viral illness features. And so this is a big one in pediatrics, that if patients have a snotty nose, you should not test them for group A strep pharyngitis. The explanation for their pharyngitis is 99.9% of the time that the same stuff running out of the front of their face is running down the back of their throat and irritating it. That's why they have a sore throat. Okay? Almost 1/4 of children receive antibiotics for viral URIs, and some doctors will say, well, we're going to start some antibiotics just to prevent bacterial infections from happening, right? Yeah, doesn't work. Okay? There's no evidence that that is a successful strategy, and there is strong evidence that it's really problematic. Approximately 1/2 of all antibiotic prescriptions were potentially unnecessary in the pediatric population. Okay? So we have to self-police. 60% of children with acute otitis media recovered within 24 hours with or without antibiotics. Europe has been using this strategy for years, where the treatment for acute otitis media is analgesic, antipyretic, and reevaluate in 24 to 48 hours. And if it's not better, then use antibiotics. Okay? That's a great strategy, and it actually is successful. But parents are not comfortable with that in the United States very often. And we have to be the primary educators. And last, antimicrobial resistant related deaths will surpass cancer. Currently the cause of death in 8.2 million individuals annually as the #1 cause of mortality. And this is the expectation over the next 10 years, 10 to 15 years. So this is one of these growing kind of insidious problems that the public's not generally aware of. And it behooves us professionally to educate the public, because ultimately they're going to have to be tax dollars dedicated to addressing the problem. So here are the leading diagnoses for antibiotic prescriptions in children. This is a 2010-11 data. And you can see on the far right here, here's acute otitis media. Well, that's largely going away with Prevnar, right? We see a lot less of that. Pharyngitis, predominantly Group A strep. Here's sinusitis. Viral URIs, not much use there. Skin infections, yeah, reasonable. UTIs, yeah, reasonable. Bronchitis and bronchiolitis, not so much, right? Bronchiolitis, viral. And then other pneumonias, a few here, but we see a lot less of those now in the era of Prevnar and Hibrix. And then another 28% of remaining diagnoses of other things for which antibiotics were prescribed. So the ultimate question for us when we're seeing a patient and thinking that we are going to prescribe antibiotics is, what am I really treating? Do I know what I am treating? And if the answer is, yeah, I don't really know what I'm treating, then don't use antibiotics, because they're not likely to be helpful. The United States uses a lot more antibiotics per capita than other countries. I don't know exactly what that means, but this is, people complain about the cost of healthcare going up. Antibiotics aren't the biggest by far. We're talking, when you look at the Medicaid dollars spent, ADHD meds trump everything else. A few years ago, Synagis trumped everything else in terms of Medicaid expenditure. Cancer medications, especially the new ones, are much more expensive than antibiotics. So we're not talking about stewardship so much from a cost-saving perspective. There's just not a lot of money in antibiotics to begin with. But maybe this is an indicator that we might be overprescribing. It's one indicator, right? All right, so what are complications of antibiotic therapy? These are take-home points that you can use, among others, to educate your patients. We know that candidiasis, when you get rid of the bacteria, yeast tend to overgrow. That's true for Candida vaginitis in women who receive antibiotics, but it's especially true for preemies who receive third-generation cephalosporins. Their rates of invasive candidiasis are 7, 8, 10-fold higher than those who haven't received these third-generation cephalosporins. We're all familiar with C. diff infection, and we recognize it can happen without antibiotics. But this is a really good and easy point to make in educating our patients and parents, because many of them are familiar with or have heard about C. diff and the dreaded fecal transplantation and those kind of things that may be the ultimate treatment for this. C. diff infection, we know what antibiotics drive it. We know how potent clindamycin is in driving it. But right now, the most common provocateur of C. diff infection is fluoroquinolones. It's fluoroquinolone use in adults. We don't use fluoroquinolones in pediatrics, so we're a little bit immune. But the data from several large pediatric hospitals is that 25% of children with C. difficile disease coming in have not had any antibiotic exposure within the prior 6 months. So that also tells us the bacteria are still evolving. And the hypervirulent, hyperendemic strain of C. diff doesn't require that antibiotic provocation. And then the selection for resistant organisms. Here's the big problem in the long term, as I showed you with those carbapenemase-resistant Klebsiella and the medical tourism. This is especially true in closed environments, ICUs, nursing homes, where it's easy to give broad-spectrum antibiotics, where the physician is looking at the patient and saying, wow, this patient's sick, they've got a new ventilator-associated pneumonia, the last time it was Pseudomonas, and we've been on an anti-pseudomonal drug. We need to escalate to the bigger guns, go to meropenem and other things, and we need to go 2 or 3 more drugs at the same time. That's okay. It's never wrong, from my perspective, to start antibiotics in an ICU patient. But you have to know when to stop the antibiotics. And that's the harder proposition, right? Because many of these patients have been not thoroughly microbiologically evaluated. We don't have a microbiologic diagnosis that allows us to focus that therapy. So they stay on broad spectrum antibiotics for a long time. I got a consult by phone yesterday about a baby who had a VP shunt infection, and they grew out enterococcus that was susceptible to ampicillin, and they called me after the baby had been on ampicillin, gentamicin, and vancomycin for 5 weeks. Like, okay, too much antibiotics. Baby, if it's susceptible to ampicillin, there's no reason to have that baby on vancomycin, right? That's easy. That's a no-brainer. And the gentamicin, they were using therapeutic doses. Not necessary. Use synergy doses of gentamicin in that case, right? It's a gram-positive organism. So thinking about how we prescribe antibiotics, and the students have all been through my lectures on, looking at classes of antibiotics, what spectrum they have, their mechanism of action, and their side effects. These are the things that we want you to think about. What am I treating and what am I not treating, and what do I need to use? Okay? And then remember those high-risk groups, dialysis, chemotherapy, and the like. Immune-compromised patients get exposed to lots of antibiotics, which leads to selection for more resistant organisms. Just as a specific, in 2013, the AAP and AAFP Clinical Practice Guideline for Otitis Media recommends a period of observation in cases of non-severe unilateral acute otitis in children greater than 6 months, and in non-severe unilateral or bilateral otitis, acute otitis media, in children greater than 2 years of age. Okay? So the professional guidance, both from infectious disease and our professional society, is in these type situations, kids less than 2, you can wait before you prescribe antibiotics, because 60% are going to get better on their own. Use the strategies, analgesics, antipyretics for comfort, and then have them come back in a day or 2. So specific interventions for antimicrobial stewardship and ambulatory pediatrics have been put forth, and education is the first one. That is educating patients about indications and risks of antibiotics. We've reviewed some of that already. Educating providers about best practices, and I'm hoping that you're getting some of that right now. Communicating strategies when antibiotics are not indicated. And that's the better viral diagnostics we have, that makes it easier for us not to prescribe antibiotics, right? And so some pediatric offices are now using the same viral respiratory multiplex panel that we use here with 23 different germs on it. Some are using that in their private practice, and it's very clear that that helps reduce the inappropriate use of antibiotics. You can tell the parent, oh yeah, it's a coronavirus, let it go. We don't need antibiotics. Antibiotics are not going to help that, okay? That helps. So better diagnostics is part of the equation, and that's one of the things we're working on. Here's that proper diagnosis. Think about acute strep pharyngitis, and we'll review that in particular in just a minute. Promoting delayed prescribing for otitis media, we've just talked about. Non-antibiotic symptom management for upper respiratory infections and bronchitis. Especially in hospitals, but in outpatient settings also, there are electronic health record prompts for diagnosis for which antibiotics are not needed. If you code out diagnosis of viral upper respiratory infection, the computer can flag that if you've prescribed an antibiotic and say, hey, these two don't go together. Think about it. Think about it. We're not changing your practice. You have to change your practice, right? And guideline discordant antibiotic choices, particularly when you're going to situations where a patient may be allergic to or have maybe a sensitivity to a particular medicine. Displaying a commitment letter, and I'll show you that. We're going to commit all doctors to psychiatric care who inappropriately prescribe. No, not really. We want to affirm the clinic and the clinician's commitment to using antibiotics only when they're necessary, and we have to educate our patients toward that. Our patients have to begin to understand that, and we publicly display that in the waiting room and clinic rooms. And then track antibiotic prescribing. If there's going to be any benefit to all the electronic health records that we have, this is one of them. Dr. Bonas sees no benefit, but I think he does. This is a challenging area, but at least the electronic health record may allow us to get some data about what's really happening. We can use that data for QI projects. We can develop algorithms, all those things, to improve our antibiotic prescribing. ER is a good one. So here's a sample commitment poster. This is a poster from this pediatrician's office, and you probably can't read it. It says, "Dear parents, we want to give you some important information about antibiotics. Antibiotics only fight infections caused by bacteria. They will not help your child feel better if they have a viral infection like a cold or runny nose, chest cold, flu, sore throat not caused by strep. If you take antibiotics when you don't need them, they cause more harm than good. Your child might feel worse. They can get diarrhea, rashes, yeast infections. Antibiotics may not work when you really need them because antibiotics make bacteria more resistant to them. And this can make future infections harder to treat." Plain and simple, easy. Educate our patients. What can a parent do? They can talk to the doctor about what's treatment's best for their child and have a plan together and reassure the parent that you are there as their provider, you're there for them. And that when they come back, if they're not better in 48 hours or getting better in 48 hours, come back and then we'll reevaluate and then we may prescribe antibiotics at that time. That doesn't prevent them from going to urgent care or somewhere else and shopping where they're going to know they're going to get antibiotics, but you've already educated them, and whether they accept that education is a different story. Here's an interesting example in a cohort study of over 50,000 patients. Those who required alternative drug regimens because of a reported penicillin allergy had higher incidence of C. diff, 23% higher incidence of C. diff diarrhea, 14% higher incidence of MRSA infections, and 30% higher incidence of vancomycin-resistant enterococcus infections. Okay? So that penicillin allergy changes our behavior. We prescribe different antibiotics in the penicillin class. That tends to promote some of the things that we really don't want happening. Okay? So if there's a question of a penicillin allergy, document exactly what it is. If it's a minor allergy, not anaphylaxis, then cephalosporins are considered acceptable to use for those patients. Okay? And carbapenems when you need them in the hospital. If it's anaphylaxis, clearly you're going to stay away from penicillins and cephalosporins and carbapenems, right? But if it's a minor reaction or mild reaction to penicillin, a mild sensitivity, number one, there's a high likelihood it's not true penicillin sensitivity. Skin testing is appropriate in those situations to help decide that. But if it's just a mild reaction, cephalosporins are okay. Here are some of the recommended first-line treatments for common ambulatory things. We've talked about acute otitis media and amoxicillin, group A strep, and penicillin, and some of the diagnostic considerations, when not to test for strep, when that kid has a runny nose, and if they're less than 3 years of age. I can't tell you how many calls I get from physicians whose patients have gone to urgent care, a 1.5-year-old or a 2-year-old who's had a monospot and a strep test. And the strep test is positive, and they've been on this or that antibiotic for a week, and it's not any better. Well, the answer is it's not any strep. And so we have to use our diagnostics appropriately. These guidelines aren't just developed out of the blue because of someone thinking, oh, that's a good idea. These are based on the best evidence we have available. Okay? If they're less than 3 years of age, don't test them for strep. Okay? Sinusitis, difficult. Parents see snotty nose for 10 days or a week. They want something to cure that, and it's not always antibiotics that are required. Most of the time that is persistent viral-mediated immune response, and stricter criteria for sinusitis improve our antibiotic prescribing. So we're not going to go through all of these. Here are our sexually transmitted infections. We have to be very worried about this in our adolescent population because we're seeing more STIs. We're also, with respect to gonorrhea, a little bit flying blind with respect to resistance patterns. What's the primary test we use for detecting gonorrhea and chlamydia in our clinics? PCR, right? Urine PCR or swab PCR. You don't get any susceptibility data when you do that. So we haven't had any susceptibility data on gonorrhea locally for almost 10 years. Yikes. A little bit blind. So pediatric and adult infectious disease groups are getting together, and we're gonna do some studies to ask what are our gonorrhea resistant rates, susceptibility patterns looking like, so we can update that, make better decisions. Okay? So common practices you may see, restricting antibiotics from general use. This doesn't happen in our hospital, but in many hospitals, carbapenems, for example, are restricted to use only by infectious disease and hem-onc. And this is a very good practice when it's rationally thought out and when it is appropriately managed with leadership by physicians and infectious disease pharmacists. Automatic stop orders for vancomycin after 72 hours. And you guys have heard me preach. If you haven't proven within 3 days that you need vancomycin, then you should stop vancomycin. Okay? That's partly because I trained in a hospital that was the rule. And if you couldn't prove you needed it, you obviously didn't need it. Okay? So a 72-hour stop rule for vancomycin, it's not part of what happens in our hospital, but it's good practice for yourselves and self-regulation to reevaluate antibiotics daily, stop the vancomycin. The less vancomycin you use, the less VRE you see in your patient populations. It's very clear. Monitoring of pharmacokinetics and adjustment programs, especially for aminoglycosides. Where do we do this? We all do it a little bit on the floor, but we specifically have pharmacists in the neonatal ICU helping to manage pharmacokinetics, doing the real math, not just the armchair, oh yeah, it looks like it's going up, going down. You know, the pharmacists in the neonatal ICU are absolutely critical to getting the doses right. Okay? And we've developed vancomycin guidelines and recommendations for initial therapy, again, to get things therapeutic as quickly as possible without a big lag, because for some of our patients with MRSA, you're banking on vanc, but if you're subtherapeutic for the first 8 days, you're not doing any good for that patient. Okay? So getting to the right level appropriately and quickly is important. Penicillin skin testing in order to reduce C. difficile, MRSA, and VRE, and reduce length of hospital stays. Very appropriate. Dr. Bana, do you want to say anything about penicillin skin testing? Okay, all right, that sounds good, thanks. Reduce the duration of therapy to the shortest effective duration. This is a difficult one because there aren't any controlled clinical trials that suggest, for instance, 4 weeks of antibiotics for a brain abscess is acceptable. So we use 6 weeks of IV antibiotics for a brain abscess, right? None of us are willing to back down on that, what is considered the standard of care, for fear that we do more harm than good. This is a very difficult area, and so with respect to osteomyelitis, we have, in pediatrics specifically, seen over the past 10 years a big switch from long-term IV therapy, and where I trained, it was 4 to 6 weeks of IV therapy for long bone osteo of the femur, and there was no deviation from that. You got a PICC line, all those things, sometimes a Broviac. And over the past decade or 15 years, that duration of therapy has come down nationally, and we've seen that it's safe. And the switch from IV to oral therapy is also happening more frequently, earlier in the process. Okay, so some of you who've been here a while will notice that Dr. Bocchini and I, even two old dogs, are learning new tricks. That sometimes we're switching kids to oral therapy after 3, 4, 5 days in the hospital. But everything's got to line up. Surgery's got to do their part, drain it. We've got to have a good clinical response. We've got to have a good clinical response that we can bank on. All of those things, good follow-up and the like, are critical to being comfortable making that shift from IV to oral therapy. But in a lot of places, that shift happens within just 2 days of the patient becoming afebrile and their procalcitonin being near normal. So these are the types of algorithms we're starting to look at, biomarkers and clinical response. But really changing to a shortest effective duration, there's just not data to support that yet. So this will be a slow evolution. Okay? We know about UTIs, right? UTIs we used to treat 14 days, all IV in kids less than 1. Now we're comfortable backing that down, get them over the acute phase, out on oral therapy, finish 10 days, you're done. Okay? Some of those type things you'll see. are moving forward. Publication of unit-specific and age-specific antibiograms. This is, I think, is a big, easy, cheap win, right? We've got all this data in the computer. Why don't we just look at it a little differently? And this is something that we're pushing for. Increasing use of rapid viral diagnostics, again, to decrease antibiotic use. It's always comforting to a parent and to us when we can say, here's the cause. It's this virus or these 3 viruses that are all in your kid's nose at the same time. That's why they're looking so sick, acting so sick, having fever, runny nose, and all those things. If we can point to a different germ that antibiotics don't require, then that's always more comforting. And yes, I actually have written this down. Consider serial procalcitonin measurements to guide antibiotic use. Okay? Yes, I did my homework. There is emerging literature that says, especially on the sensitivity side, right? If the procalcitonin is normal, low, then you can be comfortable not starting antibiotics. Okay? That's largely adult data, so our MedPeds folks know it a lot better than the pediatrics do. We're getting pediatrics data. It's a reasonable approach. We're basically using a biomarker to help quell our own uncertainty. Okay? Our gut instinct to start antibiotics and start as broad as we can and all those things. Biomarkers like procalcitonin can be useful. When I was in medical school, the CRP was all new, and everybody said, oh, this is going to help us know bacterial from viral. It's not always so clean, but when you're looking at the procalcitonin, if the procalcitonin is normal, that should be reassuring. Okay? That's the time, that's the, to me, an important way to use it. Peer pressure never hurts. This is the kind of data that you may see coming out before long. Here is physicians' prescribing practices over time, baseline, January, February, and March. Here's compared to all the other physicians in the practice, and here's compared to all the other physicians in the network that pediatrician is in. This is not just going to happen in hospitals or in clinics. It's going to happen when the insurance company provides profiles like this. It says, Dr. Vanchiere, you sure do use a lot of third-generation cephalosporins. And what about that linezolid you use? And I say, you know what? That linezolid I use is because I am the infectious disease doctor, right? So the appropriate use goes with your level of training and all those things, just like none of us would prescribe chemotherapy, right? We let Dr. Giroudi do that, okay? Same is true with some of these antibiotics. Hold them in reserve, okay? But this type of data is, are we shaming people for using too many antibiotics? Maybe. Is that wrong? Not necessarily. It is what it is, okay? And I can show you this data. If this was you, Nick, you would say, it looks like I'm an outlier. I don't have to say anything because there's good data that says, from behavioral science studies, individuals are shown data suggesting they're the outlier. They move their actions back toward the norm, okay? That's what we want. We want change in behavior. It's a good motivator. When compared head-to-head, the most effective strategy for reducing antibiotic prescriptions is individualized feedback to clinicians about their own practices compared to their peers. Okay? So don't be surprised when you get something from the compliance office that says you're billing at 99214, 15, 13, and all these things, and by the way, here's your antibiotic prescribing practice compared to your peers. Okay? Those evaluations are coming and will become the norm before too long. All right, so here's a specific example, reducing antibiotic use in respiratory syncytial virus. This is a QI project in the pediatric population. You can see there's physicians and PharmDs involved here. And this is the whole kind of schematic of it, but really the aim here was to decrease the percentage of patients with RSV exposed to antibiotics by 25% after a full antibiotic stewardship program implementation. And this requires knowledge, data, engagement by the emergency department, because they tend to, if somebody has a right upper lobe pneumonia that's a toddler with RSV, what are they going to do? They're going to put them on antibiotics. But what's the most common manifestation of RSV in a toddler? Right upper lobe infiltration, okay? So viral pneumonias are real. And when we have good diagnostics, it says this is viral, take it, accept it, because it is accurate. and then these performance dashboards. So the intervention here was evidence-based guidelines for not using RSV, not using antibiotics with RSV-infected patients, periodic review of antibiotic prescriptions, specifically in those patients to ask, do we need to continue? And work with the first-line prescribers, ER docs, and when you guys as residents are rotating in the ER, you've got a great example to influence what happens down there and say, no, this patient doesn't need antibiotics. Okay? Help them understand. So what happens in this particular project here is the percent of patients who received antibiotics, and that in their early baseline time period, you can see it was at about 50%, or is that 0.5%? I think it's more than that. And then you can see it came down here over time. This takes time, though. This is over from 2012 to 2015. And these are those control charts. They drive me crazy. Here's the total days of therapy per 1,000 patient days, another way to look at antibiotic utilization. Early on, high rates of antibiotic use, 600 days of therapy per 1,000 patient days. That's 60% of the days these kids were getting antibiotics, and they brought it down to less than 30%. So a 50% reduction in antibiotic days of therapy. Infectious Disease Society in 2010 developed this public relations campaign, Bad Bugs Need Drugs, and 10 by 20 is the initiative to develop 10 new antibiotics by 2020. Unfortunately, we're not quite on track to do that. We have a few variations of older antibiotics. You're going to see some combinations like Avicaz and some things like ceftazidime or ceftaroline plus avibactam, some expanded combinations of beta-lactamase inhibitors that will help us with, or cefepime plus beta-lactamase inhibitors, that will help us with some of these multi-drug resistant Acinetobacters that are particularly problematic. But in terms of new antibiotics, there are very few on the horizon. All right, so here's another take-home point, particular ID consult. Do I need to double cover? I get this question fairly frequently. For many years, physicians have been taught to double cover these organisms that are called space organisms. That's Serratia, Pseudomonas, Acinetobacter, Citrobacter, and Enterobacter. Okay, the space organisms. It's still in sketchy micro, right, guys? Maybe. They call it something else. Spice, sometimes they call it, but space. So recent studies have shown there's no clinical benefit to the practice of double covering for gram-negative infections. If you're treating with Zosyn or you're treating with an aminoglycoside, you don't need a second agent to have just as good clinical outcomes. And when you have two agents on board, you increase the likelihood of promoting resistance generally, but complications related to those. Okay? So double coverage is not a thing anymore. Okay? You can take that off the list of things. Now, for severe gram-positive infections, we do still use synergistic antibiotics, and you should, because these are proven to have a benefit in terms of reducing morbidity and mortality. And the common synergy drugs are going to be gentamicin and rifampin, but when you use gentamicin for synergy, it's a lower dose than the therapeutic ones we use. Typically in kids, it's 1 milligram per kilo about every 12 hours, and you don't need to monitor levels when you're using these for synergy, okay? And synergy is indicated for things like group B strep, sepsis, and meningitis. You always want gent on board for synergy. Staph, MRSA, in particular MSSA, endocarditis, excellent data, adults and kids. You want gent for synergy for the first 2 weeks of their 6-week course. Okay? Use of multiple antibiotics with non-competing mechanisms of action is justifiable for severe gram-positive infections, and we do that, right? Patient comes in with suspected staph sepsis. What am I going to put them on? Vanc, NAF, Clinda, and a little sprinkle of gent. Okay? You got 4 antibiotics working by different mechanisms of action. You're covering the background of resistance because we know 30% of our staph strains are resistant to Clinda. So if it's enough to get them hospitalized, don't bank on Clinda because there's a 30% chance you're not doing any good with Clinda alone. Okay? You've got to know your own data locally. But so multi-drug use. Is there data that supports that? Hard to tell because these are patients who are dying, and we don't want to not use reasonable practices. Okay? So finally, your take-home messages are here. Think about antibiotic spectrum, mechanism of action, and side effects every time you prescribe antibiotics. It takes just 2 seconds to review those in your head. What am I treating? What am I not treating? The most common thing I see is that we're using drugs that have a lot of anaerobic activity when we don't really need anaerobic coverage. Okay? So that applies to penicillins, but remember cephalosporins are virtually devoid of any anaerobic activity. Okay? So they're a great class of drugs. They have fewer GI side effects because of that. Don't be afraid to say no to patients and parents who ask specifically for antibiotics. Take it as an opportunity to educate them about the pros and cons. For empiric therapy, always consider the patient's history of antibiotic exposure, their immune status, and their natural barriers to bacterial pathogens, right? Because if somebody's been in the hospital a lot or has chronic medical illness, they're more likely to carry resistant organisms. And yes, empirically, you need to use broader therapy with meropenem and bigger guns. But if the patient is a normal, healthy child who's never been in the hospital and not even had otitis media, and they're 7 years old and they're coming in with community-acquired pneumonia that has to be hospitalized, ceftriaxone is perfectly reasonable there. Okay? If you suspect staph because of clinical features, effusion, and the like, add vancomycin. Okay? Think through the prescription, but especially think about the patient's history and risk factors for resistant organisms. For specific therapy, we're going to use the narrowest spectrum. Use a lot more cephalosporins than we have been using. And again, that elusive shortest effective duration and lowest cost is a factor, but it's not always the most important factor. Okay? These others weigh heavily. And support for hospital-based and clinic-based stewardship programs, because these save lives and money, and they preserve our antibiotics for future use. And that's really the goal of this: safety and preservation of these resources, because the bacteria are continuously evolving. And the likelihood we're going to stay ahead of them in the economic world we're dealt right now is not looking very good. So be strong, stand up for your antibiotics. All right, thank you. All right, Dr. Bono, would you say a little bit about penicillin skin testing and where you see?
This important topic very well, John, and I have a few comments mainly to emphasize some of your points. Number one is the education. We are prescribing antibiotics much more than necessary. You residents in the clinic are more likely to be pressured because they look at you as students, as residents, as young people. You can use the argument, my chief resident will be mad at me, even if you are the chief resident. Because the word chief is big. After that, in practice, like I use in my clinic, I have a reputation. I'm sorry, it's very easy for me to write antibiotic than to talk. But I have a reputation. Oh gosh, they respect you. The other thing is when we give antibiotic and the patient improves, and if there was a positive culture that turned to be negative, and we want to complete the course with antibiotic, they will find the fevers coming up. This is not always a recurrence of the infection. A small fraction of patients with the recurrence of the fever is drug-induced fever. You give antipyretic, which are not great. It's not toxic. Fine, and playing around. So you stop the antibiotic because you already documented improvement. And the fever within 1 day will drop down because you stopped the antibiotic. Not that you increased or added more. The major problem in this is the false labels of drug allergy in general. You look any word, you're going to find the word drug allergy, various kinds. Who said that? The patient said it to anybody, whether a nurse or a clerk or a resident, whatever it is, said, they have drug allergy, yes I do, written. No questioning. More than 90% of this is not true. I thought either related to the disease that the antibiotic was written to, which is usually a viral rash, and it's usually removed many years ago, even if it was true. Drug allergy, most drug allergies will be outgrown within a few years. And therefore, in adults who say that when I was a child I had a problem, I don't know what it is. We don't even test with the skin test. We go for a rated challenge directly to see if the patient. because it's a remote history, and there was no obvious anaphylaxis. And in children, take a good history, and if it is real, significant reaction, we will be more cautious. We do skin testing. For penicillin, it is more than 95% reliability, followed by challenge oral to see that you will not be worried about it. So I recommend for you, any chart in the hospital has the word drug allergy of any kind. Do a favor to that patient, the family, the referring physician, the whole doctor deal with that, and say allergy evaluation. You're going to find that we are removing more than 90% of that label. What a relief. We are using an alternative drug. Not just we are removing the drug that was suspecting allergy, but the whole family and cross-reacting drugs. So a large number of drugs we're going to remove. And then we are going to use a more expensive drug with more side effects, with more resistance development. We are perpetuating the problem. We just have it from the beginning. Remove it. How much pleasure for you as a referring physician and for the patient say, you are not allergic to the drug anymore. My God, I've been running with this for 10 years. And every doctor say, scratching their head for another one. Regarding penicillin testing, it's very easily done. That is, we are going to multiply. And they usually will give, and most of them are going to be negative. That's wonderful. Or we give them, if it is positive, even if it is positive, and we have the gut feeling that the patient outgrew the allergy, we are going to do the challenge. This is not orthodox thing, but for us especially, we can do that. Just like a person can cross the road on yellow light or red light even. Same. Why? Because skin testing indicates sensitization, not necessarily clinical allergy. And there were some studies were done, even the positive. Because testing, wow, deteriorated it. What a relief. So we can do that, please. Doesn't have to be done in the hospital, but at least outside the hospital we arrange that. But go ahead in the hospital, do the best. That's sufficient.
Perfect. Yes, thank you very much. Comments, questions?
By the way, desensitization can be done for any drug. Okay? We dare to do for any drug. Truly. It doesn't have to be published protocol for it. We do it. We develop it.
One of the things I want to mention is when I became a mom, I realized how much people do want to give you an antibiotic when you go to the clinic. And it's a lot of times the physician that's like, oh, but you probably want an antibiotic. No, I don't. As a mom, I really don't want you to give me one because then I have to strangle my kid and get him down and force him to take said antibiotic. So I would honestly rather you not give me one. So don't think that your parents, I know that there are some parents, I've talked to a couple of people who've gone to like South Louisiana. It's actually Mandeville where my family is. And they said that the families come in and want antibiotics for everything. Even if it's a mosquito bite, they want an antibiotic for it. So just kind of think about those things and think about, because our patient population is a little bit different. So try to learn all that while you're here too, and kind of think about like, okay, what do I want to do when I move past this place? So.
And if a parent's pressuring you for antibiotics, especially as a resident, talk to your attending. Talk to your attending about it and have them be the backup. Okay, that's part of what we're here for. Tassi.
Yeah, that was an excellent presentation. Thank you. The concept of antibiotic police, I really like it. That should be there. Kelsey is there as well. But yeah, I want to make you mentioned about the oncology patients, yes, but I want to also make a case for cystic fibrosis patients. They definitely require antibiotics. If you look into the airways of a CF patient, you will realize that how bad, how dirty it looked like. They definitely require antibiotics. And one of the things, the automatic stop order for vancomycin, I want to make a case for CF patients. Probably that should not, we should not do that.
So there are situations where that's not appropriate.
Yeah, other thing is the double coverage. Yes, we need double coverage for all those mentioned organisms mentioned, but sometimes even triple and quadruple coverage for Burkholderia and Stenotrophmonas, those kind of bacteria.
Right. You're the exception to the rule, among others. Yes, absolutely. And I think that's important to point out. It goes back to the patient's history. You got to know the risk factors and evaluate those in the context of are they likely to have resistance, how important are these organisms for them, and Sassy makes an excellent point. There are exceptions to those, but for general practice, which is the vast majority of the patients we're going to see, these are the rules, and this should be easy to follow. And if you're in doubt, call me, call Sassy, call one of us, and we're happy to help.
Just real quickly, when the residents are looking for jobs, it's a good idea to find out the prescribing practices of the group. Because I've heard from residents when they come out, Dr. Farrell, it's so easy not to prescribe that stuff when your attendings are around, but when you're out in practice, if you're in a practice where everybody prescribes, if I don't prescribe it, they go to the other doctors. So it's good to know what you're getting into, even though you're concerned about money and all the other stuff. If you're going into a group where you're going to be doing something you really don't feel good about, that may not be the group for you.
Right, and just, you can ask the group practice when you're interviewing, do you have an antimicrobial stewardship program within your practice? Because that, for any group of more than 3-4 physicians, that should be on their radar. We all need those things for MOC and all that kind of stuff. So, it's a great opportunity to do it and be the champion of it in your practice if that's appropriate. I will also put a buzz in. Remember, if a patient comes from the ER on vancomycin, that doesn't mean they have to stay on vancomycin. You're their doctor now. You can change that. We are seeing a lot of kids with acute kidney injury when they're coming up on vancomycin. That combination has been documented as particularly toxic in the adults, and we're seeing it in kids also. So don't be afraid to change the antibiotics. If you evaluate the child and say, no, I don't think they need anaerobic coverage or this or that or the other thing, change it. You're their doctor now.
Or stop it.
Or stop it. Exactly. Even better. Yes.
Also mention about bank troughs,
Bank troughs.
what
Yes.
we're aiming for.
So our aim for bank troughs is 12, 10 to 15, okay? 10 to 15 is our aim for bank troughs. The baby that they called me about yesterday was on the bank and AMP and Gen for 5 weeks, all therapeutic doses. They're like, well, the peak was 42, so it wasn't high enough. We went up. I'm like, oh my God, you're still ordering peaks for vancomycin. That went out at least 5 years ago, maybe more than that, okay? So, that happens in local hospitals that lots of kids go to. Okay, so we have to help educate out there. But yes, our bank goal for bank troughs is 10 to 15. If it's a CNS infection, we may go higher, but that's pharmacy and ID will work with you, and ICU will work with you to go higher and how to do those things. But for the vast majority of patients, the goal for the bank trough is 10 to 15.
And we will go a little bit lower, like on our sickle cell kids, those who are already on 20 mg per kg Q6, 20 mg per kg per dose,
Per dose, yeah.
Q6. Just due to the fact that that already is a really, really high dose, and our sickle cell kids do have a high volume of distribution. We're aware of that. Actually, we have one of our CF kids who's on a little bit lower right now too, mainly just because we're at a high dose already. They are clinically improving. We have not seen any resistance at this point, leaving them at an 8 to 10 range, 7 to 10 range. So
Don't hesitate to ask. And then the other thing I would remember about the CF patients is they do require higher doses of antibiotics. Their metabolism is different than non-CF kids. And so when you're seeing those patients, you're going to see them on higher doses of antibiotics. Like for septaroline, they have to be on 50% higher dose. That's real. And so don't be afraid of that. In question, ask, because they're a special group.
John,
Yes, sir.
how about topical antibiotics for otitis media compared to oral?
So the question is topical versus oral antibiotics for otitis media. I'm not aware of any data for otitis media that anything topically is going to penetrate well. That tincture of time is, to me, is the most effective strategy. And I've even, don't tell my wife, I've even done it with my own kids. When they have acute otitis media, we'll wait, wait till the next day, okay? And, but the antibiotics that I'm familiar with, I'm not aware that anything penetrates through the eardrum well enough. Now, when it's inflamed, there's likelihood that there's more penetration, but is it therapeutic? I don't think that there's data to suggest that. So
It is inflamed.
it is inflamed, right, but I don't think we're getting enough across even with the inflammation.
So what are they being promoted?
No idea. It's all money, I guess.
It's approved.
Yeah, I don't know. Particular antibiotic you have in mind?
No, because I just see it.
Okay.
Pediatric news,
Okay.
half a page about it.
Okay, well, I'll look into that too. All right, any other questions before we head out? All right, have a good one.